All right, nurselings, on to talking about chronic complications. If you are going through these videos to study for the NCLEX instead of an exam, you can probably skip this video. It's going to talk a lot about kind of the theories behind why we have these chronic complications, which you need to know for nursing school exams, but will probably have no use at all when studying for the NCLEX. All of the stuff I'm going to talk about here that is valid for the NCLEX, I'll talk about in the next video. So feel free to skip forward unless you need this for an exam. All right, so chronic complications. Biggest things that that we need to be concerned with are that diabetes is a huge risk factor for coronary heart disease and stroke. Those three things go together way, way, way too much. Diabetes is the leading cause of blindness, chronic kidney disease, and it's a huge, huge contributor to any kind of lower limb amputation, which sounds like something that only happens in like Outlander, but it actually happens in real life a lot in the hospitals, unfortunately. And these kinds of things are things that happen most of the time when patients are not maintaining a healthy glucose level. When you are diabetic but can kind of maintain that healthy glucose level, keeping your A1C at a good kind of nice plateau. For example, 6.5 is great, especially if you have other risk factors for heart disease or stroke. That actually will decrease your chances of these chronic complications. Okay, so there are kind of these two major sets, I guess, of chronic complications. You have your microvascular disease or microvascular complications and your macrovascular. Exam purposes, just need to know the difference. With micro, we're talking about the smaller blood vessels, arteries, and capillaries. These are the things that will affect your nerve fibers and the myelin sheaths and all of that. The smaller nerves that are in your eyes, and then nephropathy that has to do with the nephron. And so those are like, if you think about it, what's happening there has to do with the blood flow to and between these tiny little capillaries that are feeding nerves, are feeding nephrons, or are feeding the retina. Okay, macrovascular complications have to do with the larger vessels, like medium to large, coronary arteries, anything that's leading to a larger organ. So these kinds of macrovascular complications are going to be affecting like an organ on its own, kind of more. Like, for example, coronary artery disease, cerebrovascular disease. These are like, it's attacking the heart, it's attacking the brain, right? And then you have peripheral artery disease, meaning the main arteries in your body that are bringing your feet and your hands and all of these things, bringing them blood, right? So they're not necessarily the teeny tiny little capillaries, it's the actual larger blood vessels that are bringing blood to the rest of your body. And then on top of that, we have these other two like kind of little complications, which aren't that little: foot ulcers and infections. The foot ulcers, the reason they're not in one of these categories is because they kind of have both, in that the neuropathy that happens because of the effect on small blood vessels, the little capillaries that are bringing blood to the neurons, those are affected, and so you get this kind of neuropathy, this kind of pins and needles or lack of feeling and whatever. But then you also have this vascular insufficiency, which has more to do with PAD, where the blood isn't getting there in general. And this is where you end up with gangrene and having or giant foot ulcers that are necrotic that have to be dealt with often through amputation. So let's talk about these three or four, however many, three long-term complication theories. The reality is they don't know why diabetes, 100% why diabetes causes these. Okay, so the good news is once you look at this now and you pass this test, you hopefully will never have to think about it again unless you really, really like this stuff. Then you go right ahead. If you're like me, let's just hammer through it and then pass the test, and then you won't have to look at it to prep for your NCLEX, which is the one that matters. So the first one is this polyol pathway. So this polyol pathway has these, and we're talking, again, if you look here, the retinal, neural, and kidney cells. Those are independent of insulin, meaning, do you remember we said which cells need insulin to open up that glucose channel? We said it was the skeletal muscle and fat, or lipocytes or adipocytes. So these three here, retinal, neural, and kidney, actually don't need insulin. When you have an increase in plasma glucose, though, the blood pressure, the glucose in your blood, you then have an increase in intracellular glucose. So these here, because you have all this glucose in your blood, that glucose, unlike everything else we've been talking about, where we're like, oh, it's floating around, it's not being used, that glucose is actually being used. It's being used in the retinal tissues, the neurons, and kidney cells. And so you end up with a lot of extra glucose inside of those cells. That normal, like, glycolytic pathway, glycolytic meaning, remember that glycolysis, the beginning of that cellular respiration. So to break that down, when the glucose goes into the cell, it's used for something, right? It's part of cellular respiration. It's part of that pathway that leads us to getting those 34 ATP that we need, and that carbon dioxide that we're going to get rid of, right? So normally that's a good pathway. It's the glycolysis is the very first step in cellular respiration. But now it's saturated with glucose. There's so much glucose, the cell doesn't know what to do with it. And the extra glucose ends up being converted into this stuff called sorbitol. Sorbitol, unfortunately, cannot cross the cell membrane. So it becomes trapped inside of the cells. It can eventually be converted to fructose, which is great, because fructose can then be metabolized, and it can exit the cell that way as energy or whatever. It can be broken down. But unfortunately, that process of turning that sorbitol into glucose is very, very slow. And so that excess sorbitol just builds up and builds up inside of the cell. And as we learned about with glucose, it's going to change the osmotic gradient and pressure between the inside of the cell and the outside of the cell. And so you end up with swelling and opacity in the lens or the retina. Opacity is the opposite of transparency, like can't see through it. You have, and don't worry about this, it's a it's a bad thing that happens inside of the neurons. We're not going to go way into that. It's just too much. But what happens is it impairs the axonal transport, meaning that message that's transmitting along the axon. It's impaired. And then those Schwann cells, remember those are wrapped around those axons to make the signal move faster. Those are damaged, and then you end up with neuropathy. And remember that neuropathy, retinopathy, nephropathy, all that means is, remember, pathy is just disease or dysfunction. And so all they're saying is disease or dysfunction of the neuron or neural system, disease or dysfunction of the retina, disease or dysfunction of the kidney. If you look here, there's kind of a nice little picture of what I just talked about. So you have this insane glucose saturation or whatever. Don't worry about this stuff. This is part of like cellular respiration. And then you end up with all this sorbitol. Some of it can turn into fructose, which is great. And then very, very much of it ends up staying inside of the cell, causing this osmotic gradient shift and then damaging the cell. Okay, and that happens in all of your microvascular areas of complication. So I know I'm repeating myself, but I just don't want you to lose marks. So your 3 microvascular areas are going to be retina or retinal, kidney, and neurons. Okay? So we'll talk a little bit about that again, but let's go to the second kind of theory. So the glycoproteins are these proteins that are made with glucose. They're a part of kind of the structure of the basement membrane of a blood vessel and the capillary walls. We went through what the layers of a blood vessel are in the video on coronary artery disease, so feel free to go back and take a look at that if you want to. So what happens? We have this increase in plasma glucose, which produces these advanced glycation end products, which are basically just abnormal glycoproteins. So glycoproteins, for the most part, good. They provide structure to the cell membrane, to the basement membrane, the walls, capillary walls. Okay. When we have these abnormal kind of AGEs, that causes this oxidative stress and inflammation, which is kind of this vicious cycle where you end up with more AGEs, and then more AGEs cause more oxidative stress and inflammation. And basically what ends up happening is you have these structural deficits in the basement membranes, and that actually changes whatever properties are there that matter, that are critical to maintaining homeostasis, and it ends up with microvascular damage to the cell. So what I would remember from that: AGE's bad, glycoproteins okay, damages the basement membrane, increases oxidative stress. There's one more theory here, this protein kinase C. So we have this DAG and this protein kinase C, or PKC. These are critical intracellular signaling molecules that are responsible for regulating a bunch of vascular functions. So for example, vascular permeability, vasodilation, endothelial activation, growth factor signaling. In diabetes, these two kind of proteins or whatever are increased, so that intracellular signaling that they're doing to have all of these things happen gets haphazard, and in that way it causes vascular damage, and you end up with damage to, again, we're talking microvascular, so it's going to be retina, kidney, and nerves. Basically, the result of all of those things put together is you end up with this, possibly with this thickening of the basement membrane. And again, you can go take a look at that other breakdown if you want. Endothelial cell hyperplasia, thrombosis is possible, periocyte degeneration. Periocytes are these cells that are found kind of on and around the walls of blood vessels. You can see if you look at this diagram here. Okay, so this is your blood vessel, wall here. And you've got some neurons attached to it, and you've got some astrocytes, which are also just neurons attached. Kind of wrapped around it, you'll see these periocytes, these kind of weird shaped cells. For the longest time, scientists thought that these were there just to maintain kind of the vessel integrity, right? Make sure, give it structure, make sure it stays, doesn't collapse, whatever. It does do that. But the new studies are showing that it's essential for like the formation of vascular network. So it has like these stem cell like properties basically. So this cell here, it can actually differentiate into different cells. It can become an adipocyte, osteoblast, granulocytes. So what they've done is they've actually reclassified this cell as a certain kind of stem cell, which is kind of cool. The specific kind of stem cell that the category that it falls into, I think it's like mesenchymal stem cell or something, but they're MSCs basically. MSCs are known to play a very key role in wound healing. And so we have here these things. They're fairly mysterious, to be honest, but they're degenerating, right? It's part of the micropathic damage that's being done is to these periocytes. So they think that has some kind of link to the delayed wound healing and stuff like that. I think there was one more thing I just wanted to cover here. Yes, this right here. So glucose toxicity, it's actually pretty self-explanatory. We're talking about too much glucose. But when we're talking about glucose toxicity, it's an increase in glucose that's been happening for a very long time. It's a chronic increase in glucose, and also a chronic decrease in insulin. So you have kind of both of those things working together. What it does is basically, as you end up with all of this glucose and this very little insulin to take care of that glucose, there's a release of these free reactive oxygen species, or ROS, basically, and free radicals. We talked about free radicals in another one of the videos. I believe it was actually the one on coronary artery disease as well. Really what's important to know is that they damage the function of cells. They damage the mitochondrial function. They damage other molecules. The big thing they do in terms of diabetes is they cause that B cell dysfunction that we've talked about. That decrease obviously is going to decrease insulin and then exacerbate the hyperglycemia even further. And so you can see in this picture, like, it's kind of this very, I know I've said vicious cycle a lot, but that is kind of the theme of diabetes. You know, you've got this chronic hyperglycemia leading to glucose toxicity that's then, you know, causing further insulin resistance, destroying more beta cells, which then just causes further hyperglycemia, right? It's just this vicious cycle. And so this, along with, if you look at all of these kind of other theories that we've talked about, when you put all of those things together, those are kind of the theories as to how these microvascular complications, this neuropathy, nephropathy, and retinopathy, are coming about because of diabetes.